Care Commissioning Committee, recognising today, and a welcome to all colleagues up from North Norfolk, and recognising that we've got an important, significant item to be determined today. So just a reminder, really, of how this I'd like to run this. So for people who don't know me, my name is Debbie Bartlett. I'm the chair of the Primary Care Commissioning Committee. So this is a meeting of our committee that is in public, not a public meeting per se. So when we did this in February, we had a discussion about this in February. We followed a structure that seemed to be adequate. So I'm proposing to do that the same as last time. When we get to the item, and we've got just a few other business items to do first, I shall ask officers to first of all present the paper. I'll then invite members of the committee to check in with any clarifications they've got. And then I'd like to come to members of the public who've joined the committee and give you the opportunity to ask your questions. When we've done that, we'll then go into the committee and we will have the discussion and reach an agreement. Before we get to that, maybe I can just do the other sort of early items of business on the agenda. So in terms of apologies for absence, today we've had apologies from Tony Dean, from Bill Borrett, and from Deborah Daplin. Unless Sarah tells me otherwise, I think those are all the apologies today.
That's correct, thank you.
Lovely, thank you, Sarah. And in terms of declarations of interest, we've not had any additional declarations for today's meeting. So that takes us on to the minutes of our last meeting that was back in March. So our members of the committee, all excellent minutes as always, really clear and really detailed. So thank you, Sarah. Are members of the committee happy to agree these as a correct record of our meeting? Can't see everybody on one screen. I'm assuming I can see some nods. Lovely. Okay, thank you very much. So that takes us to the action log. And there were a couple of things on the action log. Sadie, are you able just to take us through the actions that are still amber on there?
Yes, of course. Thank you, Debbie. So the first action is not due until the June meeting. That's about the finance report. So we'll leave that on there until next month. The second action, 177 on the list, is completed. The third action was around the risk register, and that was for Shepherd and Peter Taylor to meet offline. I can't tell you whether or not that's been done, but I'm just looking at Shepherd to see if he nods or shakes.
It's been done.
It's been done. Lovely. Thank you. 179, the terms of reference, that was for you, Debbie, and Hein to meet to discuss the forward planners offline. Not sure if that's happened.
I don't think we've specifically met, have we, Hein, to discuss? We've met, but I don't think that we've had a specific focus on that. So that would be timely after this meeting to do that, I think.
Yeah, great.
Lovely, thank you. 180 terms of reference review. We have done that. The reviews were incorporated and they were approved by the board meeting. 181 also on the terms of reference, again same as above, that's been completed. 182, the delivery group report, Shepherd and Hillary to discuss the coding issues offline, and this was in relation to the severe mental illness health checks. Shepherd.
I would consider that as done. We've exchanged information that is come through from NHSE. So
Lovely, thank you. And 183 was patient awareness of discharge medication and current medication. And I think Tricia took the action on that one.
Yeah, happy to give confidence back, Chair. So as part of the work stream that has focused on discharge over the last year, we've been able to have a subgroup looking at prescribing and the challenges that happen within the hospital environment with regards to take-home medication, but also ensuring that communication between primary care and secondary care, and indeed the patient, is in the best state it can be. So I think we could close that action.
Lovely, thank you. Thanks, Tricia. Okay, that's good. All right. So then we've just got our forward planner there, which sets out what we've got in June, and we're getting into a good rhythm of the regular things that this committee needs to be looking at whilst the delivery groups do their work. So quite a full agenda coming up for June. Is there anything else, Sadie, you wanted to highlight or bring to our attention?
Nothing to add, thanks, Chair.
Okay, good, excellent. Okay, so that takes us on to item 6, the application from Holt Medical Practice. I wonder then if I could come to you, Sadie, I'm presuming it's yourself, to present the report today, noting that there is, huge amounts of detail in there. So I'll leave it to you to sort of highlight the main sort of things we need to consider.
Thank you, Debbie. And I will present on the basis that the papers have been read. This report follows on from the one that you received in February, where we agreed to defer the decision on Holt Medical Practice's application in order for us to undertake more public involvement. And I'd like to start by just acknowledging the efforts and the huge amount of engagement through the whole process from local people living in local communities and their representatives, the practice, and of course other local stakeholders. The practice has updated their application following the public involvement period that we had, and their refreshed version of that application is included in the appendices. The report content has been structured around the process that we are obliged to follow. So it goes through in order as the sections appear in the policy guidance manual from NHS England, and then it goes through the ICB statutory duties to show how we've tried to consider all aspects that we are required to do against the information that we have gathered to help us work through the practice's application. So if I talk a little bit about the public involvement process first, as that was the reason we deferred our decision. So as we said in our last report, our proposal was to focus the public involvement process on the practice's proposed medicines collection service. And that was really because there'd been such a huge amount of information collected already through various local surveys and through the engagement process that the practice undertook with the support of Healthwatch Norfolk. And you can see further detail in the report at 3.11 and in Appendix D to the report as well. As part of this, we were also glad to attend the Blakeney Parish meeting in March, and we also were invited to attend Norfolk Health Overview and Scrutiny Committee and talk more there. We again received a good amount of feedback, and all of that is highlighted in the report. And while didn't directly address the questions that we'd asked during the public involvement period. We received much more information from local people, and the themes they're set out there. So they're largely around the effect on the elderly, those reliant on public transport, difficulties in travelling by bus, and so on. I think it is fair to say that the proposed application to close the branch surgery is not supported by the local community. So moving on, using feedback from the February committee, the Health Overview Scrutiny Committee, the Blakeney Parish Council and the Practice Engagement, we went on to build quite a thorough health profile, which can be seen in Appendix E to the report. And we further developed the equalities impact assessment that we had already done, which can be seen at Appendix G in the report. There is also detail in the report at 3.2 and 4.1 on the health profile of the local population and the potential impact of the proposed closure. In addition, because we haven't seen any face-to-face appointments happening in Blakeney for 4 years, that's also given us quite a good picture of what the impact might have been on patients over the last 4 years. So we have compared data from before the pandemic to now, and we used the proxy measure of emergency admissions to consider how patients had been impacted, and again that responded to some of the comments in the public involvement phase. I think we have been able to confirm that we have seen no noticeable impact on health from the local community using those proxy measures and looking at the data, but we do acknowledge that the practice it undertakes a lot more home visits than the average in Norfolk and the average in North Norfolk. In fact, it's double the Norfolk average for their population, and we also acknowledge the additional duty arrangements that they've put in place to enable that and to ensure that home visits can be done earlier in the day. The public involvement phase also raised significant concerns around rurality and transport issues, and the report addresses that in 3.4, and there are also maps that can be seen with analysis attached in Appendix E. I think there are various options, but the Coast Hopper Bus and the Holt Caring Society were to us the main providers of community transport in the area, and also provide best value for patients. The other community transport options would prove far more expensive. Although it is noted that the Coast Hopper Bus and other bus services are particularly bad in the mornings, and do provide better access in the afternoon. In one of our conversations, North Norfolk Community Transport may be prepared to discuss developing services further for the local area, but that would be subject to funding and to being able to generate enough activity from local communities to make it economically viable for them. I think what we also saw from the work that we did was that there are quite a few geographically remote areas in Norfolk and Waveney, 72 in total, and 5 of those fall within the Holt medical practice boundary. So it is certainly a very rural area, and about 18% of the practice's population finds itself with no choice of alternative provider and with significant transport issues. So the conclusions and recommendations are set out in 6 and 7 of the report, and they were developed following consideration of all steps in the process and the ICB's duties, as well as a thorough review of the health profile of the local population, the work we did on the equality impact assessment, and of course considering the practices application. We recognise that this is a very difficult time for the local community, and it has been for the whole period that this application process has been ongoing. And it's also been very difficult for the practice. Making a decision is not easy for anybody in this. And so we have very carefully considered all of the information that we had available. On balance, our recommendation as officers is to agree the application and to close the branch surgery, but to urge the practice to work with the local community to make best efforts to continue to provide a local medicines collection service. You can see in the recommendation that we've recommended up to 6 months to enable that to happen before the branch surgery closes, if that is agreed today. And we also ask committee to support the principle of ensuring the £9,000 that is currently paid to the practice in rent reimbursement for Blakeney is made available to support any rent associated with an alternative site for medicines collection, if that is to be agreed. Thank you. You're on mute, Debbie.
Sorry, rookie error. So members of the committee, any specific sort of clarification questions for Sadie or other officers first? Hein.
Thank you, Chair. Thank you, Sadie. First of all, a very clear, structured report. So my compliments to you and colleagues, because I think by following the process, it makes it very clear to follow the reasoning of the storyline. I also would like to acknowledge the engagement from all the stakeholders that are party to this. I want to zoom into an item in the conclusions section, where it says officers have concluded there is likely to be minimal health impact in closing the Blakeney branch surgery. Now, you covered some of this in your introduction, like you've used emergency admission activity since March 2020 as a proxy. I just want to make sure I appreciate fully the various inputs that have sort of underpinned the conclusion you and your colleagues have put there. Can you elaborate on that?
Yes, of course. Thank you, Hein. So you'll see in the health profile that there are various slides towards the end which talk about the use of services from the local community to Blakeney. So emergency admissions is one of the proxy indicators that we can see, and we can see that the local population, it's exactly followed the trend that we see everywhere else, and that there hasn't been any worsening of emergency admissions that we can see over and above what we see everywhere else. You'll also see that our analyst has worked through and looked at expected activity for that local populations and compared to other. So the Melton Constable population with Holt, the Kelling population with Holt, but also other geographically remote communities and the Norfolk and Waveney average. And in most of the cases there in the graph, the health activity is actually lower than we would expect for this population, which is why we've reached those conclusions.
Thank you, Sadie.
Thank you. Okay, Trish.
So Debbie, if you wouldn't mind, I'd like to make a couple of comments and then ask a question if that's okay with you. So firstly, I have to commend the team Sadie going through all the different papers and appendixes that have come to the committee today. They are extremely detailed. They've been done with partners, and it gives a very, very good overview on the fact that the practice is very well evaluated and loved by patients, is providing very good standards of care, and is not coming to any such request for a decision by the Primary Care Committee lightly. That very much came through in the papers. My second comment was around the infection prevention control. So for absolute openness and transparency, and for those that are not aware of the workings of the ICB, as the Executive Director of Nursing, the Infection Prevention and Control team report directly to me. But they have gone out and undertaken their own assessment and come back with recommendations. So that has not in any way been influenced by my role at the Primary Care Committee. I just wanted to be clear about that. My question, however, is slightly different, and allowing for all of the complex information that the committee's received. I worked in general practice for 20 years before going into PCTs and CCGs, so I know general practice really well. And I just wanted to understand, allowing for COVID, which obviously was a huge issue for all of us in the country, in March 2020, when the services ceased, and from that point of time to now, has there been a large volume of individuals leaving the list and registering with other practices? The reason I'm asking that is if you close a branch, sometimes people will vote with their feet and will move to other practices. By remaining with the practice, that often means that people are satisfied with that arrangement based on the quality of care that they're receiving from the practice. So I just wanted your thoughts on that one, Sadie.
Thanks for that, Tricia. So over the period from March 2020 to present, we've not been made aware of any substantial changes to patient registrations. The practice has informed us that during the engagement period, there has been a small move of around 50 patients to neighbouring practices, but we're not aware of anything else. Those practices also haven't raised any concerns with us that they've been seeing any kind of increased numbers that would concern them, and normally that is what happens if practices see numbers registering from another practice. They will come and talk to us about that.
Okay, that's really helpful. And then just finally, with regards to the finances, I just want to be clear from the papers. So we're looking at an investment into the property of 245,000 plus an increase in wages of 145,000, which, Stephen, I think my maths makes it 390. Is that what the business case would look like if the continuation of the satellite surgery, if we add those two figures together?
Yeah, that's right, Tricia.
Yeah, okay.
Yeah.
Thank you very much, Debbie.
Okay.
May I just come back on that? So the staff wages increase is happening anyway, regardless of the application, because that's the rise in pay to meet the national minimum wage from April. That's happening to all practices.
Okay, thank you, Sadie, because that was the bit I couldn't quite do the math. So it's looking at a 245 investment. Okay, thank you very much.
Thank you. Okay, so with no more questions at this stage from committee members, I'll come to guests on the call. So I think we've got 11 people who've requested to ask a question and speak. I was going to do it. I was going to come to residents first, and then our local government colleagues, and ask Duncan as MP to sort of round off at the end. So I've got 3 residents who wanted to speak. So I've got Tim Ambler, Michael Archer and Sheelin. So perhaps, Tim, I could come to you first as a Blakeney resident.
It's a pleasure, and thank you for asking me. And can you hear me?
Yes, we can.
Yeah. Principle number 4 of the National Health Service principles is that the patient will be at the heart of everything that the NHS does. In other words, it should be driven by patients rather than by dare I say it, bureaucracy of the practice. So I'm not quite clear why this committee is even considering the application, because this is not patient-driven, as Sadie has already acknowledged. The case for closing Blakeney surgery, in my view, and I've read it with care, is spurious. But the most astonishing thing of the whole thing is that the whole medical practice has always refused to consult with Blakeney patients about the Blakeney surgery at all. I mean, you can say that they've been involved, they can say they've been engaged, and all sorts of sort of rather seedy words of that nature, but that's not the same as consultation. And never at any stage of these last 4 years has the practice and the patient sat down together and say, here we have a problem with Blakeney surgery not being economic. How do we solve the problem? And let's work together to do that. And that has never, ever happened, which is totally extraordinary. Then the analysis of elderly patients being discriminated against is somewhat unconvincing, if you don't mind me saying so. There's plenty of research showing that in rural parishes such as this, elderly patients are going to be discriminated against, whether you like it or not. And it is a factor which should not have been dismissed in the, if I may say so, rather casual way it has been this afternoon. And if I can refer you to research by the RCGP, which covered this extremely well. There were some minor problems, like one of the things you mentioned earlier this afternoon was that people could get a coast topper to get from Blakeney to Kelling. Well, that's pretty tricky because the coast topper doesn't go to Kelling. So that's untrue. And that's an example of a lot of things which, would have been ironed out in conversation if the two sides had met and had a proper discussion about how mutually to solve the problem. And I'm asking this committee to defer the decision again, not because necessarily you have the wrong decision. I think you have, but you think you haven't. The solution to this problem is not to sling mud at each other, but to sit down together and find a properly least bad solution jointly found. And the refusal by whole medical practice to talk to Blakeney patients at all about this, I find a complete disgrace. I don't know if the committee is aware that if you approve this application, you can expect another application next year, following the same logic as the Kelling one, to reduce the Kelling surgery hours to 3 days a week. The medical practice will conclude from a decision to close Blakeney that if they can con this, if I can use the word con rather offensively, apologies for that, if they can con this committee once, they can do so again. So we can expect the service from Kelling surgery to be cut back in a similar fashion. In short, I submit, and it's a question, will you sleep nights if you make this decision? I mean, everybody's against it. apart from whole medical practice. And yet, to go along with a few people wearing white coats killing in the face of universal disapprobation from the patients, I find quite extraordinary. That's my question. Will you sleep nights?
Okay. All right, thank you. Okay, so I'm now going to come to another Blakeney resident, so Michael Archer.
Can you hear me?
Yes, we can.
Good. I'm sorry, I'm speaking through Tim's microphone.
Okay.
Good morning, I'm Michael Archer. I'm a retired Norfolk GP and I live in Blakeney. If I can comment on two of the things that were mentioned just now, I would expect health activity for the area to have been lower since face-to-face contacts were stopped because people were unable to get to consultations. If you've only looked at emergency admissions, they are a very, very crude measure. Secondly, Patricia, you asked how many people had already left the list. Anecdotally, and it's purely anecdotally, people I've spoken to are waiting to see what the outcome of this meeting is.
Okay.
So I think you may see a lot more, you may not, I don't know. I'm concerned that the agenda patient paper mentions that the practice's average GP earnings, from which can be deduced that the full-time partners earn well over 156,000 a year. And in 2020, Holt's average payment per registered patient was double the national average. And in 2021, this rose by 24%. Holt ranked in the top 2% of practices nationally. Not only is it a dispensing practice, but as Sadia said, it's not one of the top percentage of dispensing. However, it does actually own Kelling Pharmacy. It gets dispensing income whether the patient is dispensing or not. The practice can easily afford to run and upgrade Blakeney surgery. So why does the ICB still accept the practice's contention that the cost to run the site is prohibitive? The partners want to sell Blakeney surgery, but they could sell it without closing it. Many companies offer sale and leaseback on GP premises, and why has the option of sale and leaseback not been explored? It's nonsense to claim that a multidisciplinary team cannot operate effectively at Blakeney. If there's one thing COVID has taught us, it's that remote supervision of clinical teams works. I did it myself throughout lockdown. Apart from the duty team at High Kelling, and I do agree, apart from the duty team at High Kelling, all members of the team can work at Blakeney. They don't have to be there at the same time. They can be supervised remotely. So why does the ICB accept the outmoded idea that all members of a multidisciplinary team must be in the same building? In recent weeks, the ICB has produced a highly inflated figure for the cost of refurbishment of Blakeney surgery, using a figure based purely on national average costs and building size, rather than relying on a detailed review commissioned by Norfolk & Waveney CCG, specific to this building and its needs, which was prepared by a firm of architects and cost consultants with considerable experience of healthcare projects, including several surgeries in Norfolk. So why has the ICB ignored that detailed review in favour of a much higher average cost? Patricia, going on to the infection prevention and control, following the publication of new national standards in 2021, in September 23, the CQC produced a full update of its GP Mythbuster 99 on infection prevention and control in general practice. It states, for example, that carpets and curtains are allowed. There simply needs to be a protocol for cleaning and for dealing with spillages. There's actually very little that needs to be done at Blakeney surgery to make it fully compliant for infection prevention and control. The cost should actually be less than the Chaplin and Ferrand estimate of 2021, because they included replacement of all furnishings. It should not be more, as the ICB is now saying. In any case, ensuring that premises meet the required standards is the practice's responsibility under paragraph 7 of the standard GMS contract. And given the content of that Mythbuster 99, why does the ICB continue to support the practice's assertion that infection prevention and control are a bar to providing face-to-face consultation? I think most importantly, though, local access to services and the lack of governance over withdrawal of face-to-face consultations at Blakeney are, of course, the major issues to consider today. The research that Tim referred to actually was done in Norfolk as part of a PhD thesis at the UEA, and it hasn't been mentioned at all. Every member of the HOSC who spoke at its recent meeting, felt that Blakeney surgery should remain open. Why is the ICB still pushing to close Blakeney surgery? I'd love to hear answers to some or all of those. Thank you.
Thank you, Michael. Thank you. Then I wanted to come to Sheelin Cuthbert from Field Dawling, please.
Thank you. Good afternoon. My father bought the Blakeney surgery in 1932 from Dr. Kay, and the surgery was run at the back of our house. So I grew up with the surgery and always at the back of the house. The patients were part of our lives. Of course, in those days, compared with the medicine today, whatever the doctors did was limited compared with today. But I can assure you the patients were very well cared for by someone who knew them and they knew the doctor. Only today I was at the Glaven Caring Day Centre, where there were patients of my father's who still remember him as a real friend to the whole family. I know things have changed, but it's inevitable that people would like to go back to what they remembered as their childhood, as in mine. I'm really upset that you're considering closing Blakeney surgery, because not only Blakeney people, but people from Langham, Morston, this village of Field Dawling and others can get to Blakeney. It is much easier to be given a lift to Blakeney than it is to High Kelling. High Kelling is a long way. It's the other side of Holt. And a lot of elderly people, unlike myself, of course, find it difficult to drive that far. The day I cannot drive, I wish, please, to go into the next world, because not being able to drive, to see a doctor when you want to collect your medicines or collect them for other people, which we do a lot, is a very sad day. I'm sure all of you sitting around this meeting can drive. Do you have parents who don't drive, or uncles or aunts? How much care do they need? Going back to the Blakeney surgery, I can understand why the doctors prefer to meet in Holt or High Kelling. We call it Holt, but it's High Kelling, because they don't live in this part of the world. A lot of them live in Norwich or near Norwich. And by the time they've driven to Holt, coming on to Blakeney is another 6 miles, and it takes them another 20 minutes and they might be late. It's probably easier for them to get to High Kelling, but we need them in Blakeney. We need a doctor's visit. We need to be able to visit the doctor. They seldom visit us in homes any longer, for one reason or another. I'm sure practical reasons, a lot of them. But if they were visiting people's homes, it would help their medicine so much, because if you walk into someone's house, you know whether they can cope. You know whether they're mentally and physically well just by walking into the house. It's a great pity that doctors don't visit often enough, but I can't change the whole health service, I realise. But please do not close Blakeney surgery. We, all of us in our rural villages, need it. We need to visit doctors there, and of course we need to pick our medicines and order our medicines there. Please think of the patients, particularly the elderly patients, which so many of us are. Thank you.
Thank you, Sheelin. Thank you. Okay, so I've now got a number of speakers from parish councils. I wonder if I could start with Blakeney. So I've got Rosemary Thew, who's the chair of Blakeney Parish Council, followed by Nigel, who's the vice chair.
Thank you, Chairman. Can I just check that you can hear me all right?
Yes, we can. Thank you, Rosemary.
Thank you. Well, on behalf of our parishioners, Blakeney Parish Council regards the recommendation to close Blakeney surgery with incredulity and despair. We believe the withdrawal of face-to-face consultation to have been wrongly handled. You have heard about that already, but there has therefore been no consultation about that. The consultation has been about medication, and the mitigation proposed continues to be inadequate. We hope the committee has properly read the comments made in the surveys reflecting patient concerns, the difficulty of travel to High Kelling and the costs that some who can ill afford it will bear. It is worth reflecting that when the main surgery moved from Holt to High Kelling, mitigation was based on the fact that there were 2 branch surgeries. If Blakeney is closed, there will be Melton Constable only. And for how long? Parishioners are being let down by broken promises. The previous meeting decided that the ICB should explore the practice's proposed mitigation to offer a medication collection service in Blakeney. I have to say that little has changed since the last meeting. There remain unresolved discussions with alternative sites. If no alternative is found, there is the prospect of temporarily running the service from a container. That is a disgrace and simply not acceptable. Other mitigation remains predicated on patients travelling to High Kelling. That is also not acceptable and misses the whole point that travel from Blakeney to High Kelling is difficult and costly. An expansion of the car service is likely also to be difficult, as volunteer drivers need to be found. Even if they are, patients have to pay for the service. If the ICB accepts the recommendation to close, asking the practice to make best efforts to agree a location for a medication collection service, and to do so within 6 months, do the ICB intend to review the action taken by the practice, or will they allow closure to happen anyway? Thank you, Chairman.
Thank you, Rosemary. So Nigel Sutcliffe, Vice Chair of Blakeney.
Can I just check, can everybody hear me?
We can hear you, Nigel, yep.
Okay. Not only am I speaking as Vice Chair of Blakeney Parish Council, but perhaps more importantly, I'm speaking as a patient of Holt Medical Practice for the last 22 years, who has had those elderly associated conditions, if I can say, which need addressing. And up until 2019, I didn't have any problem. I just walked down the road and received appropriate treatment, appropriate medicine. Then for reasons that are still really unexplained, everything just stopped. The dispensary was removed, face-to-face interviews were removed, and more importantly, there was absolutely no discussion with patients about this. It just happened. And then we get COVID, of course, and of course, you know, COVID's a good thing to hide behind, if truth is said, about how you handle things. Now, it's at this point that Blakeney Parish Council got involved because we were wondering what was happening. Why have services been removed? Why can't they be reinstated? And we commenced a dialogue with Holt Medical Practice in November 2021. And I have to say, they really failed to engage in that. We offered to have discussions with them as to how we could progress the matter. Nothing happened. And there's a singular failure to get involved, as Tim touched on earlier. I also have to say that the ICB in a similar way failed to get involved up until very recently about mitigation, about what on earth it was going on with the medical practice. And it's a sad state of affairs that Holt Medical Practice couldn't follow NHS guidance to be able to deal with things properly and in an effective way. And the whole thing to me has been a shambles. And anybody who attended the open day on the 1st of August last year at Blakeney Village Hall, you'll see the strength of opposition that there is to the closure of this surgery. It's huge, absolutely huge. So my request to you today is to urge you to reject the application outright. It's a bad decision. Thank you.
Thank you, Nigel. Thank you. Okay, so I've then got 3 more parish councils. So I've got Alex Hooper from Stiffkey Parish Council first.
Yes, good afternoon. Can you hear me?
Yes, we can.
Great. So I'm asking today that the recommendation to close Blakeney surgery is rejected. I ask this because I believe that the ICB has fundamentally failed in its legal obligations to follow due process, and the process that has been followed is riddled with flaws, inaccuracies and obfuscation, much of the information prepared after the fact. The obligations under the NHS Act and the Policy and Guidance Manual to consult with patients has not been undertaken with regard to face-to-face appointments. The mitigation efforts are focused solely on medicine collection, and even the papers prepared for this meeting show a disregard for the impact of the decisions on real lives. In fact, you appear to have socially profiled the population that accesses Blakeney surgery as being so wealthy that it does not matter. This is manifestly untrue. The reports and documentation provided last Friday show a disregard for process and transparency. There has been little opportunity for public engagement, scrutiny and accountability. And even what does exist now, such as the EIA, skews data and information and disappointingly seems to focus its potential action on training for staff at Holt Medical Practice. This hardly seems to address the inequality for patients. The ICB needs to demonstrate that it takes governance seriously by starting this process again and undertaking it correctly. Can you explain why you feel the NHS Act and Policy and Guidance Manual is not relevant in this circumstance? And further, why you feel that the patients who use Blakeney surgery are not worthy of a proper and comprehensive consultation with regard to face-to-face appointments? And should you accept the recommendation to close through option 3, how are you going to ensure that all mitigation measures are put in place and effectively work? And particularly given in light of your failure to undertake a proper public consultation and therefore have no real baseline data, how are you going to measure the true impact of this decision and redress it if necessary? Thank you.
Thank you, Alex. Thank you. So I've got Moreton Parish Council. I think it's Rob Metcalfe.
Yes, good afternoon. Morstan, in fact, but
Sorry,
not far away. So my question concerns the use of research data to justify a closure decision. Apart from the scandalous fact, I believe it's scandalous, that the withdrawal of face-to-face appointments has not been properly considered in this process, I'm also dismayed by the partial use of misleading statistics to build a case for closure. My interest is in those who are disadvantaged in terms of health, personal mobility, those from manual social classes, the elderly, and those without cars. Part of the statistical case for closure seems to be that because there are marginally fewer of these people in Blakeney's surgery's catchment, their needs are less important than those who live near Holt or Melton. This is appallingly discriminatory. These people have not been properly considered at any stage of the consultation. And the equality impact assessment is flawed in using short-term and post-COVID data. Emergency admissions as a proxy do not measure the long-term effects of closure. As has already been said, important research carried out in Norfolk and published in the Journal of the Royal College of Practitioners has also been ignored. This shows how already disadvantaged groups are disadvantaged further by branch surgery closure. This is a regressive move. It will cause real harm. So my question is, how can the practice justify ignoring the needs of a significant minority of the nearly 2,000 people who live in Morstan, Blakeney and surrounding villages? Thank you.
thank you. Thank you. So field calling, Chris Gadsby.
Hello, can you hear me?
Yep, we can.
Okay, thank you. So I just wanted to talk very briefly about health inequality, which I think a number of people have already referred to, but I think it's worthwhile emphasising. And specifically that the equality impact assessment that was carried out as part of this elongated process ignored the fact that face-to-face appointments had not happened in Blakeney for a number of years. And this decision to cease these appointments was never therefore subject to that impact assessment and indeed the due process of consultation. I'm new to this process, but I'm reliably told that this failure to follow procedure is subject to a referral to the Secretary of State. So it'd be interesting to know what the status is on that particular point. Clearly, our view is that the equality impact assessment should be fully considerate of public connectivity issues. Lots of people have already talked about public transport, so I won't dwell on that, but it's a 3-hour round journey from Blakeney to High Kelling on public transport, which doesn't seem to be a reasonable ask of people, particularly of vulnerable patients who seem to be hit disproportionately whether they're physically, socially or financially vulnerable. They will be further disadvantaged in terms of their inequality as a result of this recommended proposal and the inequality of care that they can easily access. So my last point is that the Equality Act of 2010, section 149, states that public authorities must give due regard to the need to eliminate discrimination with respect to the ability of everyone to access health services. And clearly, people should not be subjected to inequality based on characteristics such as age or disability. And clearly our view is that that's exactly what this proposal is doing. Public bodies, of course, should seek to reduce inequalities and not enhance inequalities, which this proposal seems to be based upon.
Okay, thank you, Chris. Thank you. Okay, so I've got, I was going to come to Victoria Holiday next, if I may, in your role as both District Councillor and Chair of Clyde Parish Council.
Thank you very much. Can everyone hear me?
Yep.
Based on previous experience, you can. Okay. So feedback from the public engagement on the proposed closure shows an overwhelming demand to keep Blakeney Surgery open and to return to face-to-face appointments. This reflects the observation in your report that it is accepted that accessing primary medical services may become significantly less convenient for some patients. I'd like to correct that may to will and quite significantly. Your worst case scenario of the time it takes some patients in the Blakeney Surgery catchment to get to High Kelling by bus is in excess of 60 minutes. However, have you considered, and I have gone through the Sandhurst timetables in quite detail, it can be an almost 5 hours round trip to High Kelling and 7 to Melton with 2 changes and a half-mile walk. You also state that Blakeney has an older population than other areas served by Holt Medical Practice and higher than average number of patients with long-term conditions. Have you considered patients may have more than one long-term condition? About 55% of those over 65 have 2 or more health conditions, 75% of those over 75, and about 85% of those over 85 years old have more than one long-term condition. Have you really considered the health impact of moving care away from patients? A systematic review of research looking at the association between travel time to healthcare services and health outcomes showed that 77% of the studies demonstrated worse health outcomes the further the patient was from healthcare facilities. These outcomes included survival rates and length of stay in hospital. And I agree with my colleagues that considering emergency admissions as a proxy is completely inappropriate for the effect that the forced closure of Blakeney Surgery so far has had. I also refer to the research carried out in Norfolk showing that branch surgeries improve the accessibility of general practice to patients and serve an underrepresented and disadvantaged group of patients. Their closure, therefore, has a disproportionate effect on already disadvantaged people. Mindful of this research and of travel times and demographics, is the ICB assured that the health of Blakeney Surgery patients will not be adversely impacted by the closure of Blakeney Surgery and the withdrawal of face-to-face appointments from Blakeney? We ask you to reject this application. Thank you.
Thank you. Okay, so I think then I was going to come to Steve Blatch, who's Chief Executive of, I don't know if you're speaking for yourself, Steve, or whether you're representing your leader, I don't know.
Good afternoon, Debbie. Good afternoon. So I have a prepared statement on behalf of North Norfolk District Council. North Norfolk District Council wishes to record its concern and disappointment over the recommendation made to the ICB to confirm the permanent closure of Blakeney Surgery for the following reasons. I speak on behalf of North Norfolk District Council as a corporate body, with a motion passed unanimously at the September 2023 full council meeting, stating that the council recognised the critical importance of Blakeney Surgery to the community and called on the Norfolk and Waveney ICB to provide local and equitable access to healthcare for those living in Blakeney and the surrounding community. My comments today seek to emphasise those issues as agreed by the full council motion. Blakeney is a relatively large in a Norfolk context village on the North Norfolk coast. It occupies a location at the centre of the Norfolk Coast National Landscape Area and is highly rural. The village and its immediately adjoining communities of Clyde next to the sea, Langham, Morston and Wiverton have a resident population of some 1,600 people, according to the 2021 census. Significantly, a very high proportion of those residents are aged over 65, 43.7% of the population, against a North Norfolk average of 33.4%, a Norfolk average of 25%, and an England average of just 18.4%. The Blakeney surgery is a branch surgery of the Holt Medical Practice, which has its main surgery at the Kelling Hospital site. This is 1.3 miles east of Holt and also provides a branch surgery at Melton Constable, some 6.2 miles to the southwest of Holt. The Blakeney surgery is 7.2 miles from the main practice surgery by road, but is not served by any direct public transport. There is also no direct public transport between Blakeney and the branch surgery at Melton Constable. Public transport services serving Blakeney are essentially the Coast Hopper bus, which follows the A149 coast road between Wells next to the sea and Sheringham and Cromer, and does not serve Holt or the Kelling Hospital site. If the Blakeney surgery closure is confirmed, access to the Holt surgery at the Kelling Hospital site by public transport would involve a minimum of an hour's bus journey in each direction, with a change of bus at Sheringham, so involving a minimum of a 3-hour round trip. There is a limited direct service between Blakeney and Holt, the Sanders number 46 service, but this only has services leaving Blakeney at 6:31, 9:05 and 11:05 a.m. Monday to Friday, with return services from Holt at 7:50, 12:35, 14:20, 1800 and 18:50. But these services too require catching a connecting bus between Holt Marketplace and Kelling Hospital. I believe the statements in the papers suggest that the X44 service between Sheringham and Holt, including High Kelling Hospital site, is half hourly. That is not the District Council's understanding of this position. It's more likely an hourly service. Car ownership in the area served by the Blakeney surgery is lower than the North Norfolk and Norfolk averages, possibly reflecting the older population in this part of the county. In the 3 lower super output areas which cover Blakeney, the number of people with no access to a car is higher than both the North Norfolk and Norfolk averages. In the lower super output area where the Blakeney surgery is located, 25.2% of households had no car. In the Blakeney High Street, lower super output area, 17.9% of households had no car. And in the lower super output area covering the parish of Morston and the Morston Road in Blakeney, 16% of households had no car. That compares to 14.6% of North Norfolk households having no car and 17.4% of Norfolk households. Again, that covers urban areas where car ownership is lower. So those figures for Blakeney are high in comparison to very many rural parts of Norfolk. It is well documented that older people, often with multiple chronic conditions or multiple comorbidity, attend GP appointments more frequently than the wider population, and the closure of Blakeney surgery will significantly impact older people within the Blakeney area, making access to primary care more difficult for them, reducing their independence through them being reliant on friends and neighbours for lifts to the main surgery at Kelling Hospital, or having to access community transport through Holt Cares, which is understood to have a limited number of volunteer drivers. This situation will be further compounded through local people being unable to collect regular or repeat prescriptions from the Blakeney surgery. The permanent closure of the Blakeney surgery also...
Hello?
Mr. Andrew, can you turn your microphone off, please?
Microphone on. Thank you.
Thank you. The permanent closure of the Blakeney surgery also appears to go against the policy position promoted by the Chief Medical Officer, Professor Chris Whitty, who in his 2023 annual report, Health in an Ageing Society, states, "For policymakers, the biggest concern I have is that government and professional bodies have not recognised the degree to which the population living in older age is concentrating geographically in the United Kingdom in general and England specifically. The great majority of people move out of cities and large towns before older age, concentrating geographically in coastal, semi-rural or peripheral areas, often with relatively sparse services and transport links. Manchester, Birmingham and London will age very slowly, but areas such as Scarborough, North Norfolk or the South Coast are going to age rapidly and predictably. Providing services and environments suitable for older adults in these areas is an absolute priority if we wish to maximise the period all older citizens have in independence. The provision of health and social care also needs to be concentrated in these areas." The Holt GP practice is understood to have 8 GPs and 10.5 allied healthcare professionals, with an average GP patient ratio of 1 to 1,700 patients. It is difficult in this context to understand why the Holt practice cannot continue to operate the branch surgery at Blakeney, perhaps on a 2 or 3 day a week basis, attended by a GP, practice nurse and healthcare assistant or member of reception or support staff, recognising the issues of lone working. But that would provide continued primary care and prescription services in the Blakeney community. It appears instead that the proposed permanent closure of the Blakeney surgery is more for the convenience of the whole medical practice rather than patients and community of Blakeney and surrounding villages, with local residents having to make frequent and multiple trips to the Culling Hospital site to access GP services at their own personal cost. The proposed closure of Blakeney surgery therefore goes against the principles of patients being at the heart of everything the NHS does. It places elderly and vulnerable residents at a disadvantage in being able to access primary health care in terms of independence and cost, and represents the loss of another service to rural communities in North Norfolk, alongside banking services, dental services, pharmacy services, and the availability of all affordable housing, all of which are contributing to a fundamental change in the structure and viabilities of communities across rural North Norfolk. For all of the above reasons, North Norfolk District Council would ask the ICB not to approve the closure of Blakeney surgery. Thank you.
Okay, I'm presuming from the way you read that, that's written down, so it'd be helpful, perhaps, if you haven't already, to share a copy with.
That's fine, Debbie. Yes, happy to do that. Happy to do so. Thank you.
Okay, thank you. So finally, and I have let this run, so thank you for colleagues on the call for sticking with it. Duncan, recognising that you'll probably bring this together. Maybe request that we don't perhaps repeat stuff, but I'm sure you'll be very adept at being able to bring out the key points and summarise for us.
Yes, thank you, Debbie. I will try not to go back over all of the parts that have already been discussed, but I think what Steve Blatch, the Chief Executive of the District Council, has just surmised there is an excellent summary. The first thing to say is that I do declare that I am a PPS for the Health Secretary. I have never used my influence to bring this case to her attention specifically. That would be improper. But I should mention that I am involved in the Health Department. It is clearly what feels like a very sad day, dreadfully disappointed with the situation that we end up in, and it has to be somewhat of a fait accompli, I think. This is a decision which all of the members of the ICB today that are present on the meeting will not just impact Blakeney residents, but tens and tens of villages neighbouring as well, which will make up quite literally hundreds, if not thousands, of people, many elderly and vulnerable. And of course, you can see that, Debbie, with Morston, Field Dorling, Stiffkey alone, all on the call. I think it's also unprecedented, I think, to have a local authority chief executive on the line as well to present the corporate view of the council. Such is the amount of emotion and despair at this decision. I think it gives you a sense straight away of how wrong so many people think that it is. But it's not just the fait accompli of the decision hanging over Blakeney surgery, but it's one also about the face-to-face appointments. That's never really been concentrated on, nor has the failure to look at the original process that effectively, very sadly, I think has been the green light for signalling the closure of the surgery. There's just been somewhat an acceptance that those face-to-face appointments were going to be lost. I don't think the ICB have really focused on trying to rectify that, and it has been called scandalous today. And I think people need to reflect on that. So, as Steve Blatch just mentioned as well, much of this ought to be encapsulated by what Professor Chris Whitty, the Chief Medical Officer, has signalled when he has specifically singled out North Norfolk over 80 times in the report in 2023. I have the privilege of sitting around the table with Professor Chris Whitty once a week. And for somebody of his stature to be telling people that North Norfolk is particularly vulnerable because it is an ageing area, the demographics are so ageing, and that it urgently needs more healthcare And here we are staring down the barrel of the complete reverse of that decision today and actually closing healthcare facilities. So, of course, I will come to what I think you should be making a decision on later on, but refusing the application or at least mitigating further in a moment. My job is to represent constituents. You know that. I don't think that's a million miles different to what the ICB should be doing, actually. The ICB is funded by the government and taxpayers and is responsible, therefore. And I've said this to you all before, it has always felt there has been far too much of a foot of leaning on the leg of saying that we are recognising the issues for the surgery and not so much the patients. And I think that is an imbalance, Debbie. I think there has to strike a balance. I recognise how GP practices are suffering at the moment in the face of very difficult times, but so are patients. And there's been an imbalance to represent the wishes of the surgery over the wishes of patients. And I have to say, and I'll choose my words carefully, I feel very let down, not just by the ICB, but by NHS England as well. Both have spoken to me privately regarding mitigation. And there was somewhat of an agreement that we will attempt to put together a decent package. Now, Rosemary Thew from Blakeney Parish Council, I think, was very polite when she said that the package of mitigation was inadequate. It's not inadequate, it's pitiful. It is absolutely not changed from the discussions that we had all together some months ago in Blakeney Parish Hall. I can't see what's happened. And considering that we put this cumulatively with Benjamin Court closing and now a medical practice in my constituency, you can understand how upset I am about how the ICB is making decisions in my constituency of North Norfolk, the oldest demographic in the entire country. And I'm realistic. I didn't think that we would ever get face-to-face appointments back again, but the scale of upset this has caused, I did think that you would at least look at a decent compromise. But just a dispensary service for medication collection is absolutely not revisiting the mitigation at all. There's been nothing on transport mitigation, not even a limited funding for a short period of time, like you get a Section 106 agreement, some sort of limited service to try and help the most vulnerable people in a very, very rural area. Not even perhaps a shared space for a very limited amount of time per week around the Blakeney area for face-to-face meetings to still and appointments to still happen for very elderly people and vulnerable people. Not even considered in the report, not in the mitigation. So I'm going to wrap up now, but the community and the campaigners and everybody that has spoken today represents how the wider community feels. You know, you've got a district councillor feeling like this, you have parish councils across Blakeney, Stiffkey, Morston, residents as well, but also, Debbie, ex-doctors, people who have been in the profession that feel like this as well. And I think listening to them, if you don't listen to people like me who are just elected to serve, but actual medical healthcare professionals, they are people that really should be listened to. So I do pay a huge tribute to the campaign group. As has been said, this matter has been referred to the Secretary of State. I do not know what the Secretary of State is going to say, but I would urge the committee to do two things on this, recognising that actually this has gone onto her desk. NHS England have prepared some documentation. I believe that they were asked for more information. That's all I know, and there is no decision yet. I would wait until NHS England have given that information and the Health Secretary has made a ruling before the ICB makes a decision. It's my first thing. And I think secondly, this mitigation, as I keep saying, is not adequate. And so I would bring together the transport, some sort of ability for still elderly people to see a nurse or a doctor, coupled with the decision that the Health Secretary makes, should all be brought together before your committee makes a final decision. Thank you.
Thank you very much. So all those who've spoken, thank you. You know, I do appreciate your cooperation in this, and you know, absolutely recognise, you know, the strength of feeling that you've all expressed there, and the breadth of views as well. So thank you for that. So having done that, if I can then come back to committee members. Probably, Stacey, I should just say that we will, of course, you know, there's huge amounts in there in terms of questions, in terms of points that have been raised. I don't know whether there are any you specifically wanted to pick up now, or whether, of course, as is, we will do a full response to all of those. Is there anything you just wanted to pick up now?
Thank you, Debbie. And yes, we will work on a full response to all of those questions, which we'll publish on the website along the papers, alongside the papers. Maybe two or three things, if I may. Throughout this, we have tried to ensure that the practice is continuing to meet the reasonable needs of its whole practice population, which it is required to do under its GP contract with us. And I think, having looked at the health profile, the numbers of appointments, the numbers of home visits, we have concluded that the practice does continue to meet the reasonable needs of its practice population. Emergency admissions generally reflect unmet need. The levels of emergency admissions reflect unmet need, which is why we use that as a proxy indicator. We don't see any evidence that health outcomes have been affected over the last 4 years. And I know there have been comments today on the fact that face-to-face appointments haven't been provided in Blakeney since the surgery closed for the first lockdown. So the practice does appear to be continuing to meet the reasonable needs of its population. And we know that the practice has been providing a lot more home visits than other practices do, and has arranged their services so that they can do so. And if the level of access appears to be consistent in terms of the number of appointments offered, there hasn't been any reduction in that with the loss of those face-to-face appointments in Blakeney. They've been provided in the other two surgeries. And of course, we know that medicines is a concern for many people that have responded to the public involvement phase, and the practice fully intends to ensure that they can continue to offer that, but they will need the support of the local community to arrange that provision. And finally, I think there were a few concerns raised about the process. So for committee members, we have had a legal review of our process to ensure that we have met our statutory duties and that we've complied with the national process set out in the NHS England Policy and Guidance Manual. And in fact, what we've tried to do is to reflect best practice in doing this, rather than go with the statutory minimum requirements around the process. So the legal advice was satisfied with the process that the ICB has undertaken. And you'll see in the report that we have also sought support from the NHS England regional team around our call-in responsibilities under the new Secretary of State call-in powers that came into effect at the end of January. So I think that's probably all I would like to say at this stage, Debbie, but very happy to have any further questions. Thank you.
Okay. All right, so I'll come to other members of the committee now. So Trish.
So, Sadie, thank you to responding to a sort of a summary of the points that have been very passionately raised here today. Can I just go back to one point that you made with regards to a legal view? So one of the themes that was coming through from a number of people that have spoken today is around the face-to-face consultation aspect not having been consulted upon. And for me, that's a very important point of clarification with regards to the process that has been followed by the ICB, because it's one of our principles that we want to listen to people. So from the legal view, do you feel that that was considered, or whether there's a further thing that we need to do?
Thanks, Tricia. Yes, that was also considered. So the practice removed face-to-face appointments at the onset of the COVID lockdown, the first COVID lockdown. They were providing face-to-face appointments up until the week beforehand, and they have confirmed that. The temporary decision not to restart face-to-face appointments was based on the infection prevention and control issues that that have been highlighted, and as you say, your team went out and inspected the branch surgery themselves, and we spoke to the legal advisor about the temporary decision, and it was felt best to include that within the decision that we make today. So it had remained a temporary decision, but it will be wrapped up in the decision around the future of the surgery today.
Okay. Other comments, other questions, other reflections from members of the committee? So I guess, you know, while people are gathering their thoughts, it's important, isn't it, for us as a committee to remember what we're being asked to do in reaching a decision. So what we have is an application from one of our primary care teams from Holt Medical Practice to make a change that leads to the closure of a branch surgery at Blakeney. In reaching that decision, we need to abide by the criteria that are given to us, and those are set out in section 3 and section 4 of the paper, and taking all of that into account and recognizing, you know, the fine sort of weighting and balance between all of those things, reach a decision. So you know, I guess I'm keen, Sadie, to confirm that we have followed that due process and considered in some detail, and that the conclusion that's set out in section C weighs those together and comes to that view.
Yes, I sought legal advice on that, Debbie, and it's confirmed that we have.
Okay. So, unless there are any other people who want to ask a question from the committee who are members or raise any comments, I think then, you know, looking at section 6 and the conclusions in there, notwithstanding, you know, the fact that this is a hugely difficult decision to reach for people, I'd sort of come to the members of the committee, the voting members of the committee, and ask you then, on the basis of that conclusion, whether you accept the conclusion and therefore whether you agree the recommendation that is set out at section 7. So I can see some nods there. I wondered if you'd just mind raising a thumb or something like that so that we can just capture that. Got so many people on my screen.
Yeah, Debbie, it's Hein. I'm happy to 3.
Okay, so taking that into account then, that is the decision we reach, can we talk a bit more about the mitigations that are in there? So we've heard a lot about and seen through the feedback we've had over the course of what has been, you know, a very extensive engagement proposal, I would suggest. That mitigation is around the medicines service, but actually, you know, whether or not there is more around there. So Sadie, would you mind just sort of setting out, you know, summary for the record, really, what the mitigations in summary are that we're agreeing to or we're looking at the moment?
Yes, of course. So the practice have said that they are happy to continue to provide a medicines collection service in the Blakeney area. They have that would be on a similar basis to what we have now, subject to them being able to agree a suitable location. The practice have tried to agree a location earlier on in the process, but the people that they approached were not happy to continue any of those discussions until a final decision had been reached. So once a decision is reached, the practice will be able to reach out again to those locations, consider any others, and then work through the logistical preparations for putting that in place. And that's why we suggested an up to 6 months period that they would have to do that. Obviously, if they're able to work through those logistical arrangements more quickly, they would be able to move the service over more quickly. But we don't think it's reasonable for this to be open-ended for the practice, given that, you know, if the committee does approve today, which I think you have, so that is why the length of time has been given as it is there.
Okay, thank you, Sadie. I can see your hand, Duncan. I'm just going to hold it for a moment, if I may, please. So yes, we have agreed the recommendation, just for absolute clarity. I wonder whether one of the things that I've been struck by in reading all the paperwork that's gone with this, and in listening to some of the things come today, are about the sort of the ongoing evaluation and review of the impact of this. And whilst it's not in the paper, you know, I would like to ask the ICB to go away and think about actually how this can be formalised and some sort of evaluation done of what the impact of this is. You know, we've talked today a lot about the pressures that there are on primary care, the pressures that there are on the health service, particularly in geographically remote areas. So I think it's a really important piece of work that may well be transferable. So I'd like to request that. The other issue that we haven't, that isn't in the sort of the recommendation, is around public transport. The ICB is not responsible for public transport. You know, it is. So however, I think, you know, the issue of access and accessibility to public services is one that is very relevant to health and social care. And I know that Heather is here from the Place Board, and I'm wondering, you know, Mark, whether it would be something that actually the Place Board could consider going forward.
Yes, Debbie, absolutely. We can pick that up to follow, picking up on comments made here today around the transport. Absolutely. Working with colleagues.
Okay. Duncan, I'm sure you don't want to embarrass me as chair of the committee in terms of the sort of the terms of reference of this. And this, as I've said, is a meeting of the committee in public, not a public meeting. But given on this occasion, I'm prepared to sort of stretch the rules a bit, you know, invite you back in, but frame it as a question if you wouldn't mind.
I've no intention of embarrassing you, Debbie. I know you well enough not to do that. My only question is, do you not have a vote? How does your committee system work? Do you not have a individual vote on the recommendation? Is that it? I only saw one hand go up. Can you just explain to me, is that it? You've just decided and I didn't see any voting at all.
So there are 4 voting members of the committee. So there's myself as chair. There is the director of nursing at the ICB, the director of finance at the ICB, and the vice chair of the committee, that is Hein. So I can confirm that they supported this and therefore we have agreed it.
So it's a unanimous decision, is it? Can you confirm?
Yes, yes, I can. Okay. So I'm very sorry, but I can't take any more discussion on this now. I'm quite sure you know you will want to contact us again and be in touch. But I think that you know, if I can say, you know, these decisions are not ones which are taken lightly. I think you know the extent of the work that has gone on, the professional sort of background information that's been produced to arrive here, you know, demonstrates the seriousness with which these decisions are taken. I do recognise that people will be very disappointed, and you know, I guess, you know, that's why there are people like us who have to make difficult decisions. But I do genuinely feel that the work that's gone on locally to raise the issues, to ask questions, you know, to bring us to this point, have significantly contributed to the mitigation and the further work that will now take place. And whilst I'm sure that isn't, you know, compensatory, it does, I hope, you know, go some way towards recognising the efforts that and the genuine feeling that's gone on. So I'm going to move us on now to the final item that's on the agenda. Guests are more than welcome to stay because this is, you know, just as you know, a highly important area as well. But of course, I understand if you want to leave, but feel free to continue to attend and listen to the discussion. So we're moving to item 6, which is the long-term dental plan. Now, Sadie, is this, oh, this is Fiona, isn't it? Okay, so Fiona, welcome. You know, maybe you could talk us through the main elements of this, please.
Yeah, thank you very much. So the paper that's before you sets out the long-term dental plan for approval. And I will take the paper as read, but happy to answer any questions. But if I could just make a few points. First of all, I'd like to start by saying a really big thank you to all of our colleagues in the dental profession who've provided invaluable support, advice and guidance to us over the past year as we've been developing our plans. And also the support we've received from our system partners, particularly the local authorities and colleagues also in ICBs in the east of England have been hugely helpful, and we continue to want to work collaboratively. And actually it'll be critical to us to be able to do that for us to be able to deliver our plans successfully. And I'd also like to thank the public and our patients for engaging with our survey earlier in the year. We were delighted to receive so many responses, as you can see from the report. And also that there was widespread support for our priorities for the next 2 years, because obviously we realise this is a difficult challenge. The feedback that we received around the urgent treatment service will also be enormously helpful in helping us to develop that service going forward. I think it's fair to say that improving access to local dental services is not going to be without its challenges, and it will take time. Having a sustainable workforce plan and building resilience and stability across all of our services is critical. And I think we recognise that it's going to be a step-by-step approach, and that widespread improvements for our whole population are likely to take longer than the lifetime of this plan. You can see from the plan, hopefully, that it's not just about improving general access, but also about ensuring that pathways are in place for onward referral for more complex treatments when actually needed, for example, to level 2 services, community dental or secondary care. I think hopefully you'll see that the plan lays out the foundations for us to make real and lasting improvements in access to NHS dental services. What we've tried to do is to set out the key pieces of work we need to deliver to be successful, although detailed plans are required for each programme of work, where they're all not already in place. We've also identified the benefits and outcomes if our plans are achieved alongside proposed timeframes for delivery of each element. As we indicated in our survey earlier this year, our priorities for this year and next year will be to start to improve access in areas of deprivation and for our most vulnerable patients, to address health inequalities, and also that we focus on children and young people. And our proposed investment commitment for this year reflects those priorities. This year will also be quite a lot of work involved in starting to plan future service developments and actually the next steps in delivering our plan. I think it's fair to say that the ICB team is small in terms of those involved in dental services across the ICB, and therefore we're limited in how much can be achieved and how quickly we can move things forward. And fundamental to this is encouraging dentists and dental care professionals to come and work in Norfolk and Waveney. I would also like to highlight the fact that some areas are outside our control, such as dental contract reform and national workforce plans. But we will be doing all we can to secure and develop services for our population. And we will continue to work with system partners, the dental profession, and our colleagues in the East of England. Our intention is to review and update the plan annually, and to re-engage in 2 years' time with our local population to ask them how we're doing and whether any change has been seen. I'll leave it there for the moment, but I'm happy to take any questions.
Okay, great. Thank you very much, Fiona. So we've this has been, we've had the short-term plan, and I actually just wanted to acknowledge the impact the short-term plan has had. And it's contained in here, but within a short time, there has been a difference in that regard. You have a small, but perfectly formed team is what I might say. So what we always knew was that actually that was some immediate actions that could be taken, but what would make a sustainable difference would be a long-term plan, and so it's great actually to have that here. I like the emphasis on the children's and young people's. I think that makes a real preventative sense, and that's really welcomed. I'll open it up first and to questions and comments from members of the committee first. Colleagues. Hein.
Thanks, Chair, and thanks, Fiona. I would echo what you say, great response rate. So I think that's very encouraging as you put this report together with the various stakeholders. I have one request and a question. So I support the plan as presented. I would make one tweak in the next steps, because your proposal is to report on progress to the committee annually, and I really feel we need to see that much more frequently. So I would plead to do it quarterly, because this is sort of the handrails with our quest as committee to be more strategic. I think sort of hold the finger to the pulse. It would be good to see it on a quarterly basis, ideally a mix of both qualitative insights and quantitative, because I think as ICB sort of we're asked sort of, or people ask, show me that indeed progress is being made, and I think it's sort of incumbent on us to live up to that. So that would be my encouragement. My question was about the urgent treatment pilot or service. The sort of feedback in the pie chart gave cause for some concern. I know it's being reviewed. Could you shed a bit more light on where that stands, or when you hope to report back on that?
Thank you, Hein. So in terms of the urgent treatment service, we are intending to carry out a review, speak to all the providers, also IC24 and NHS 111, and colleagues in our urgent and emergency care team. The concerns that have been raised are obviously what we are doing is providing around 1,800 appointments per month, with maybe a small handful of people who are not turning up. When I say a small handful, we're talking 2 or 3 people. But there seems to be concern as to whether the messaging and patient expectations and what the providers are telling patients, what NHS 111 is telling patients, and whether the two are in sync. So we need to just check and confirm what's actually happening. It's not surprising. We put the service in place really, really quickly because people told us that's what we needed to do. So 6 months on, I think it's time for a review and see where improvements can be made. So that's our plan. I would anticipate it bringing back to committee in September, but it probably will go to a delivery group before then.
Yep, thanks.
Tricia.
Thank you, Fiona. I'm very supportive of this long-term plan in view of the state of dental access that we have across Norfolk and Waveney. But there's a couple of points I'd just like to understand better. Regarding children's oral health, we know that with regards to acute activity, that under 4s are presenting to have extraction, which is really concerning. And I know that we've got this absolute commitment here for us in health. I'm assuming it's going to be well supported by our colleagues in public health to ensure that we have that maximum impact into the communities, into education, and we can really drive forward improvements for our children. So that was my first question. And then the second one, in the short-term opportunities, it's showing as a review of UDA rate review. But I think what I heard you say was that this is nationally driven. So is there an opportunity for us to do something locally? Is that what you're saying in this report?
Thank you, Tricia. So in terms of your first question, there is a task and finish group which is led by our colleagues in Norfolk County Council Public Health Team, looking at children's oral health education and prevention, and we sit on that group. In turn, they also sit on our task and finish group, looking at the establishment of child-friendly, child-focused dental practices, so that we can ensure that we're whatever we put in place supports each other. And we're also working closely. We're also working with Suffolk County Council in terms of Waveney around oral health education and prevention. In terms of your second question, the UDA rate review that we arrived at of £30 is higher than the recommendation from the national team of 28. We agreed it some months ago, and the UDA rate uplift came into effect on the 1st of April. We're now currently developing a framework that will look at how we can respond to not only ad hoc requests, but also to look further and in more depth in perhaps areas of deprivation or where there's greatest need, and how we can look at the UDA rate and see whether there's a need to uplift it. I think it would also be fair to say that we're also trying to move away slightly from UDAs in the way we commission. So when we do go out to commission other services, we will try to commission differently. So hopefully all that coming together will help support practices.
Thank you, Fiona.
Thank you. Nick, I'm so glad you put up your hand, because I was going to call you in and ask you, you know, for your views on this. So go ahead.
Thank you very much. Just for those who don't know me, I'm the dental advisor to this committee. It's a huge amount of work that the ICB are having to do. They've almost given a hospital pass, really, by NHS England to have to deal with NHS dental services at primary care. And it's not a surprise that there are huge numbers of areas that they're having to work on at the moment. One area I would suggest we need to look at, certainly if not necessarily this year, certainly in a very short space of time, is those residents in care homes and nursing homes. They don't have much of a voice. And that's shown by the response that we got from the survey. There was a very small number of responses from those in those kind of environments. But we do need to work quite closely to develop that. Now, I go back and say again, we have been doing, there's a lot of areas that we're having to work on. And I think the priorities are right, but let's not lose sight of those vulnerable people who probably don't have much of a voice. The other area I think we probably need to keep our ear to the ground over is undergraduate dental training. There has been some discussion recently about the possibility of training undergraduates in this area, whether it would be for a full-blown dental school or some sort of outreach centre from a current dental school. But I think we need to keep our eyes open to that as a possibility, and that was really the report or the long-term plan was silent on that to a degree. So those are areas I think that we mustn't lose sight of going forward. But apart from that, I think there is a lot of work that's been done already, and there's a lot of work to be done. I think the support of our dental colleagues in the county is greater than many other areas in the country. And I think that's something that we need to harness and work together closely with. Thank you very much.
Thank you, Nick. You know, and I think the point you make about care homes is well made, actually. So thank you. Okay, I think it's Jason who wanted to come in now.
Thank you, Debbie. Again, I would like to applaud the whole team for the effort they've put in. Number one, the hard work that's delivered the plan. And number two, the application of the team here at the ICB, which has not been uniform throughout the region. So I would echo Nick's comments and be entirely supportive of the team. I think Nick raises a very important point about that sort of egg group in care homes who do not have much of a voice or much of much advocacy. The point I wanted to make specifically is when looking at page 12 of the long-term plan, we can see a reference there to utilising clinical leadership fellows, health inequality, and also level 2 service provision. Now, with my other hat on, working for NHS England in the Workforce Training and Education Directorate, you know, I've talked about the fact that if we're going to get people to come and work in places like Norfolk and Waveney, there has to be a reason to come here. You know, we don't have a dental school. We're not necessarily close to large major urban areas. So the one thing we can say is that there's a good quality of life, but also there's a good quality of professional life. And that means that people need to come and feel supported. There has to be a professional infrastructure here. And as Nick has highlighted, we don't have a dental hospital. We may gain some extra educational facilities in the future, one hopes, but my dreams have been dashed before, so I'm a little bit sort of cynical about that. But the one thing I would say is recently the level 2 pilots for periodontics and endodontics, which are a key area where young professionals quite often want to develop their skills. Well, they've finished now, those pilots. And so we're lacking that sort of substance to our offer to come here, gain skills and stay, and then provide those enhanced skills to our local population. So I'd pray in aid that I know it's more difficult. I know it's more difficult. Sorry, I know it's more difficult for a single ICB to work towards that, but if we're not going to be backed up by our other colleagues in the region, we do need to do something.
Okay, that's really helpful. Thank you. Just to feed into the committee, the Norfolk County Council today agreed, you know, across the council, a resolution to lobby for a dental school in Norfolk, and I'm sure Norfolk and Waveney, you know, you can feed into that. So, you know, in terms of actually, you know, a wider recognition of the value that would bring. You know, that's not just the ICB saying that. I think wider partners are saying that now. I wonder then if I might just make an observation, Fiona, and it might be that I've missed this elsewhere, but I guess what I'm keen to understand is to what level are we seeking to improve access to NHS dentistry? You know, I think I've heard said, you know, from national experts, commentators on this, that actually, you know, to get it back to where it was at its height would you know, break the bank entirely. So what, at some point, it would be helpful to have some idea of what our ambition is in Norfolk, and then be able to sort of, you know, track our progress towards that.
Yes, thank you. We did have quite a lengthy discussion actually about whether we should set ourselves a target in this plan in terms of patient access. And we felt that it was too soon, a year into our responsibilities. But as part of reviewing it next year, our intention will be to consider whether we can set ourselves a target. Nationally, we have been asked to restore UDA activity to 2019 levels.
Okay.
But I'm not sure that necessarily this is a good measure for us, because as both us and many ICBs across the country are looking at flexible commissioning, which is moving away from commissioning services using UDAs, it kind of makes restoring UDA activity to 2019 levels more difficult to measure. The one thing that we can measure easily is new patients and the number of new patients that are being seen and treated. We will be monitoring this closely during the coming year and see if we can start to see a trend and whether we can set ourselves some targets around this. And if I could just respond to Nick's question around care homes. One of the advantages that we do have of working with other ICBs in the region is that we're aware of pilots going on in other ICB areas, and one of them is around care homes. And so rather than starting with a blank sheet of paper, we can look at their scheme and see whether it would work for us or whether it needs to be adapted. Obviously, with Norfolk and Waveney being a much more rural county and also having a significantly large number of care homes. The one thing that we are being asked to do later this year is screening in special educational needs schools. So we will obviously have to look at that and how that will impact our plans to improve access and general oral health education as well. I should probably also say that the plan you see in front of you is probably quite short on workforce detail, but there is a significant and substantial amount of work being done by our primary care workforce team, working with NHS England and colleagues to look at how we can encourage dentists and dental care professionals to come live and work in Norfolk and Whately.
Okay, great. Trish, your hand was up. It's gone down. Has your
I
question-
give up with my hand today. It just isn't doing what I was intending it to do. So, I was really interested, Nick saying about care homes. I was really interested what you said, Fiona, about SEND and education. Unless we not forget the adult persons with learning disabilities who will require reasonable adjustment, especially when we know the learning from the leader review says cardiovascular disease, diabetes, etc., are all burdens of comorbidities for that client group. And I know it takes time, and I know it takes special people with some of the more vulnerable members of that cohort. But let's keep waving the flag to make sure they've got the best services we can.
Yeah, that's great. Okay. You know, pass on our thanks and appreciation of the, you know, the quality of what this is, Fiona, to the team and to yourselves. You know, so I think, you know, we're being asked to agree this and approve it. I think we're very happy to do that. So thank you very much. Okay, so right, so that's it. I don't think there's any AOB on this agenda. Nope, no one's signalling. Great. Okay. Shall we have, for those people who are joining the part 2 meeting, shall we reconvene at 3:30? So 9 minutes to take a break. Thank you very much, everybody, for your input and your papers. Thank you.